Hi, I'm Stephanie Shelton, and this is Conversations on Health, How We Get There, Episode 14. Starting in mid-October and ending January 15th, millions of eligible Americans who don't get health insurance through their jobs or through Medicaid can use what's known as the Open Enrollment Period to sign up for or change various insurance plans. Medicare recipients, mostly 65 or older, have just 6 weeks this year, ending on December 7th, to choose supplemental insurance or Advantage plans. And those who ever want what most of us call Obamacare, which is health insurance created under the Affordable Care Act, can change or enroll starting November 1st. That's the easy part. The rest, like virtually everything about healthcare in the United States, is really, really, really complicated. So we're going to spend some quality time on this episode and the next one, getting to know how it all works. How do you navigate an insurance marketplace? Why do plans vary from state to state? What should you watch out for? And what about the cost? Our guide through all of this is Dr. Stephen D. Culler, Associated Professor at the Rollins School of Public Health and Affiliated Associate Professor at the Guazetta Business School at Emory University in Atlanta. Steve, thank you so much for being on the podcast.
I'm glad to be here.
When I realized it was open enrollment period coming up in mid-October, I get the shakes dealing with insurance. It's so complicated. So am I the only person in the world who just looks at this thing and says, oh my God, I've got an affordable care plan. I got to look and see if it's still the same plan, or I have a Medicare secondary plan. What am I going to do?
No, I think that the United States has always been unique in the sense that they've never had a national insurance plan. Healthcare has always been a state-regulated industry. So even back before Medicare and Medicaid, the national programs for the elderly and the poor, health insurance was very different, even in the employer sector, state by state, because of the different state laws. So it's always been a very, very confusing mess about who and how you get your insurance. And so I always like to think about it, for most part, there's 3 buckets. There's the elderly who get Medicare, the poor who get Medicaid, and then if you're young and working, you get employer-based health insurance, which typically includes the whole family. And then there's that 20 to 40 million people in the United States now that fall somewhere else, and of which that the Obamacare exchanges, the public exchanges, pick up about 20 million of those people.
So again, spending a lot of time in Europe, everybody's the same.
Right.
Everybody's covered by the same insurance.
Yeah.
How do we ever get to this situation?
Yeah, I mean, I think I always say that we had a bunch of historical accidents, and some of them is part of the culture, sort of that Western, every person goes for themselves, and the community takes care of them, the people in their community. But when the European countries around 1900 were doing national health insurance, there was no interest at all in the United States for that. And in fact, we didn't even have health insurance in the United States until almost the 1940s of any real type. And so, and again, I always like to say, to some extent, there wasn't a lot that doctors and hospitals could do for people, and the bills weren't really high. So people in the United States didn't worry about that as much. And we've never been big into public health or prevention in this country, other than clean water. This country's always been different, I think. And then I think, given how spread out this country is compared to European countries, our whole healthcare system is so different because of that space. And it's like I say, Georgia, the state of Georgia I live in Atlanta, is probably larger than half the European countries.
Yeah, exactly.
And then you got states like Colorado that have, 2 million people over 200 million square miles. So it makes healthcare very, very different in the United States.
let's kind of start with the open enrollment period,
Yeah,
which I believe begins um, November 1st for the
first, right,
affordable care people.
right,
And if you could just explain a little bit about what it, for people who don't have it,
yeah,
and they've all heard of Obamacare, they may not
right.
have heard of affordable care.
Yeah. So again, they're actually the same thing. So that so if you don't have employer-based health insurance, if you aren't in Medicaid or you're not in Medicaid, then you can actually buy a private or a public health insurance plan from the exchange. And again, the exchanges are public exchanges. There's an enrollment period. And so you go out there, and then based on the county you live in, you will see options to buy the insurance. So health insurance companies, actual private health insurance companies, are actually offering their health insurance package to individuals who are going to buy on the exchange. Okay.
Are these tailored? I mean,
Yeah.
is it different than if you got it from your employer?
So it's actually probably better insurance than what your employer offers. So again, what happened is that to be on the exchange, there's the federal government and the Obamacare mandated services that had to be covered. Okay, like hospitalizations, and there's 10 big branches, and then each state health insurance commissioner can actually outline what those insurance coverage contain. So that would be how many, what the different coverage might be for different types of services. And again, things like mental health, how many days of mental health do you get? How many days of skilled nursing would you get in that package? And then in the exchange, there's 4 levels of premium. So, and they go from bronze to platinum, and they're supposedly set up so that, depending on your health conditions, whether you're sick and going to use a lot of care, or whether you're pretty healthy and not going to use care, you can individually probably save money by buying a lower premium or a higher premium plan.
So this all started in 2010, right?
Right. Yes.
And before that, there was this group of people who had nothing. They
Right. There was 20 to 25 to 30 million people uncovered, depending on who you believe. Yeah.
And if let's say you're a freelancer,
Yeah.
I am,
Yeah.
and you don't get any union health care, or you don't
Right.
have any
Yeah.
employer health care, are there income limits? How do you
Yeah.
qualify for this kind of?
So originally, the way it was set up was in the 2010 was that if you qualified for Medicaid, which was 130% of poverty, you were too poor to be in the exchange. Okay, and you had to take Medicare. And then there was subsidies to help you pay your insurance up to 400% of the poverty line. And then after 400% of the poverty line, if you bought a plan, you paid the entire premium out of pocket. Okay. But you had to buy one of those approved plans from the thing, where I'll just go back, if it was 2009, the year before, and you were self-employed, there were a bunch of insurance companies that sold a variety of packages that had different levels of coverage. So I could buy a catastrophic plan and maybe only pay $1,000 a year in premiums because I was young and healthy and I didn't think I was going to need it. I could buy an insurance plan that had prenatal care because I thought I was going to get my wife, we're going to have a family or something. So there were other alternatives that got labeled as bad health insurance during the Obamacare debate, because they didn't have full benefits. But they served a purpose in the sense that there were people who knew they wanted this set of benefits and didn't want everything else, right?
And you
So
can't get that now.
and you can't, well, you couldn't until the Trump administration, and then he allowed some of those plans to come back in, and then in the Biden administration, some of those plans have been eliminated, but there are still a few of them left out. And you can actually buy them on the exchange, but they're not actually labeled exchange plans. There's something else. So, but
maybe you can understand why my head is like,
yeah, yeah, right. No, it's very, very confusing. But for the most part, if you go on the exchange, you have one benefit package. It's community rated, and then you have a choice of how you want to pay out of pocket versus premium monthly.
Right. And again, if you could explain, you talk about marketplaces and
yeah. So
does it differ from state to state? Why not just a federal marketplace?
Yeah. So again, because health insurance in the United States is regulated at the state level, even in the employer business, people don't know this, but you take because they've been in the news, GM, who has plants in 7 different states, they actually had 7 different health benefits because each state regulates those benefits slightly differently. So what happens in the United States is that it's state regulated. So every state health insurance commissioner gets to determine exactly how they're going to meet the benefit package in the Obamacare ACA exchange. And so those are slightly different. And then the marketplace is actually at the county level. So every county has a different set of insurance plans that are putting their premiums out there that I could bid on. So I would go out. First thing it asked me is what my county is in Georgia. I put in Fulton, and then it pops up with 350 healthcare plans that I can choose from.
And then in the research that I did, it said these are plans you can take with you, but it doesn't sound like that's true.
What do you mean?
If you move from state to state?
Well, I mean,
what if you get transferred?
Yeah. So I mean, I assume what they're saying is that if you had a plan in exchange, you move, you're guaranteed extend a plan in exchange. So that's just called the fact that once you're insured, and then you get sick and you move or something, then the next company can't exclude you because of pre-existing conditions. So the exchange got rid of all that. This was a problem with employer-based healthcare, and it still is in the United States to some extent, not as bad as it used to be. But it used to be that if you got sick and with diabetes or cancer and you lost your job and then you got better and could go back to work, you often didn't qualify for the new employer's health insurance plan. Okay.
But now
there's even in the private sector employer health base now, there are you can't be kicked out of the plan because you get sick.
I thought, again, this is from my own reading, that that was finished forever, that you could not be denied health insurance, period, the end, because of a pre-existing condition.
Well, I mean, that was the goal of the Obama plan. Yes.
But it didn't happen.
Well, I mean, I would say it's still true in that if you want to go into the Obamacare plan, that's right, it still happens. But again, if it's not necessarily true 100% at the employer level.
I mean, so you could, if you were denied health insurance, I mean, again, this used to be, I remember this. People were afraid if you had cancer, you were afraid to go to another job.
Right. That's exactly right. Now, if you lose your job, again, there is some minimum period that they cannot cover you, but it's less than a year. Also, there's COBRA that allows you to use your past employer's plan for 3 or 4 years. You have to pay all the premiums, but so there's much better coverage that way. But again, if you don't work or you work, you can still go buy Obamacare. It's only if you're on Medicare or Medicaid that originally you weren't supposed to be allowed to buy the exchange. So you can turn your employer plan down and use that money you save in the premium to buy a policy on the exchange.
So there's a way.
Yeah, there's a way now to get coverage. Yeah.
Because if you have cancer,
Yeah.
let's say, and you get continuing like breast cancer,
Right.
where people get continuing treatments or have to take
Yeah.
continuing drugs, and you change jobs,
Yeah.
you can't afford to pay for that yourself.
Right. Yeah. No. So that was, and again, that was probably the the number of people who didn't have any insurance was the number one reason the exchange got created, and then the second reason is exactly what you're saying: this continuation of care, and the fact that, as I always say, what most people never understand: when they're working, they love their employer health plan, but what they don't realize is that if they get really sick, they're probably not going to be able to work, and they're not going to have their plan. And so that disconnect has always made it always stuns me when I see these polls that 90% of the people who have employer health-based care want to continue it, or 80%, whatever the number is. And it's like they don't really understand how the plan works.
I guess until you get sick or you look
Yeah.
for another job or
No,
whatever.
that's exactly right. It's not until you get sick that you really understand that, especially if you get sick that you can't work, that you really don't have health insurance now.
Right.
Now that you need it, you don't have it. So yeah, that's the problem.
So different from Europe.
Yeah, right. And that's where I say, that's where, and again, I should have said this at the beginning, but one of the fundamental things that sort of got started because health insurance came through work is this country has always had this belief that if you're not working, you don't deserve health care. and that you see that almost every poll. It's still 35 to 55% of the people in the country, depending on how you ask the question, don't believe you deserve health care if you're not working in this country.
No wonder we have all these diseases that are preventable.
Yeah. No. And again, you look, I mean, even in the state of Georgia right now, there's this big argument about whether or not people have to work to get Medicaid in this state.
Somebody ought to do some traveling.
Yeah, right. Well,
it's one of the goals of this podcast, and one of the reasons I started it, to start letting Americans understand how other people deal with healthcare.
Right.
It does vary from country to country, but in general, in an advanced country, everybody has some kind of healthcare.
Yeah.
Except us.
Yeah. Well, and then what I always say, that then the other side, which is not the purpose of this thing, is that those people who have coverage, end up utilizing it or overutilizing it to an extent that's just incredible compared to other countries. So we get more knee replacements, we get, we have more MRIs, we have more hospital or doctor visits and all this stuff, but we don't do more prevention.
No, exactly. These affordable care plans differ from state to state because they're registered in various states, but not all states.
Right.
Do you still get, if you were to move, say, from New York to Texas?
Yeah.
Would you still have a plan that has the core features of the plan that you had in New York?
Yeah, I think that the variation is very small between the states. It's got, and in general, if you move from New York, you're probably not going to get everything because they're probably more generous historically than Texas. But if you move to Texas to New York, you would end up getting a bigger benefit package for the same plan. Yeah.
Okay.
Yeah. And we're talking about things that may or may not, it has to do with, just what gets covered, and exactly how much gets covered. And there's small variations in that kind of stuff, Okay. And a lot of it would be like the new drugs, the diabetes, obesity drugs that have been approved for diabetes, but haven't been approved for obesity, even though they've shown that you lose weight. So again, whether that drug gets covered in one state or the other for obesity would depend on how rigid they are on exactly only paying for drugs that have been approved for that reason.
And that could change during.
That could change from state to state because of the health mandates.
It could also change in the plan if.
Right. Yeah. The plan could limit it or have they might have to cover it, but they could limit how many days worth of coverage they give you, you know.
Okay, so let's move on to the Medicare open enrollment, which
right.
begins about the day this podcast will publish.
Yeah.
What's different about that from what we've just been talking about?
Okay, so let's go back and do a review on Medicare. Okay, so historically, Medicare.
Yes, Professor.
Historically, Medicare had two parts. Okay, they called it Part A, which was the hospital facility part, and you paid into Social Security in the United States if you work 16 quarters during your life, and you have free hospital and Part A facility care, less a deductible, which was historically 1 day in the hospital. So that was your deductible. So anytime you were in Medicare, you had a hospitalization, you had coverage under Part A. Okay. And then you hear the hospital trust fund going bankrupt. That's what people are talking about, that the payments in are not large enough to cover the payments out. So the trust fund is going to go bankrupt in 2038 or 33 or whoever the latest thing is. But that part was traditionally Part A. And then the physician part B, because the doctors didn't want Medicare, only covered 25% of the physician bill. And then there was a supplemental policy you bought to cover the rest, but it was paid out of general revenue, so that's never going to go bankrupt. So that's Part B. Okay, so historically, when you turned 65 and weren't working, you joined Medicare, you got free Part A, and then you had to typically you bought a supplemental policy from an insurance company to cover the rest of Part B that didn't get paid. Okay, right. And those premiums were, my mother got them. Those premiums were like $200 a month.
That's a lot.
Yeah, on top of whatever you paid in all your life in Medicare. Okay, so that was how historically that Medicare worked. Then back in the Bush administration, we split out. I think it was the Bush administration. We started to let people have Part C, okay, which is what you're talking about with the open enrollment. And so the way I always think about Part C is that I give up Part A and B, and I go out and buy from a private insurance company, maybe Aetna, my same company I had and I worked with, a managed care plan that covered all Medicare benefits.
But okay, that would be that's called an Advantage plan, right?
That's called a Medicare Advantage plan, yes.
You don't have to do that.
You do not have to do that. When you join Medicare, you got that choice. And there's some real complicated rules, but you can choose every year to go from Part A to Part B, or Part A to Advantage. But if you've been sick, the private insurance companies don't have to take you. Okay, and then there's some rules that if you're really sick, whether or not you can come back to Part A and B from Part C. But again, those are minor details, and they're very complicated on that kind of stuff. But in general, as long as you're healthy, any year you can switch back and forth. Most people don't. Okay.
It seems to me the Advantage plans. I know that there's. I'm after SAG after my union all my life, and I had a wonderful union plan that I qualified for, working in union covered broadcasting, as a journalist. But when you got to be 65, and this is true in every company I know, there is now a requirement basically that these plans, if you have a union plan or a company plan, they flip and they become your secondary.
Yeah.
And you have to take, even if you're still working for the company, they push you into Medicare so that the company pays less for health insurance.
Yeah. So again, That varies in the United States. So I work at Emory, and I have the right to keep Emory insurance and not take Medicare. I'm over 65, so I'm actually still on the Medicare plan or the Emory plan because it covers my wife, and so the benefits are slightly better for me than Medicare benefits. There, so there is that. It depends on the employer on whether or not in the United States when you turn 65. So what happens if you take part A and B and work and pay the insurance? Medicare's the secondary. So if you have two insurance plans, Medicare is the secondary coverage.
Yeah.
Okay. So that's how in general that works. So what I was going to say, what happens when you buy into the Medicare Advantage is you're choosing between alternative private insurance packages that have an actuarial value equal to what Medicare's Part A, Part B are.
Yeah.
Okay. Because the selection bias, younger, healthier people tend to go into Part C, then these plans have now offered benefits that aren't in Medicare to encourage people to buy them. So you might get eye care, you might get dental care, you might get more mental health care, you might get more preventive care. So again, you might even get some population health, some exercise club, a swim club. There's a lot of things that these plans tack on that gets the actuarial value up to what this healthy person would have. And so that's why, and they can lower the premium. So that's why you have people that, like Joe Namath doing, I don't know if you've seen the Joe Namath commercials where I got free healthcare.
Yeah.
Right.
So I have looked at the AFL-CIO Union Advantage plan.
Right.
It's Anthem.
Anthem. Okay. All right. So the Blue Cross plan. Yeah. Okay.
And this is for every union that okays it.
Yeah.
So it's if you take the first plan, you basically pay nothing a month.
Yeah, right. And again,
high copays.
Yeah, and that's great as long as you're relatively healthy. But if you have a stroke, what you're going to find out is that because of the way they set their plan up with their limits and where the out-of-pocket stuff comes from, you may not get the same amount of rehab facility care that you would have gotten under Part A of an old Medicare plan. So you are giving up things. You just don't know what you're giving up if you don't read the premium. Really, you got to really understand the benefit package. You got to really understand what happens to a person with a stroke versus a person with a heart attack. So again, sometimes if you have history of stroke in your family, you would never want to join a Medicare Advantage plan because of the lack of the minimum coverage that's actually provided for those services and what becomes out of pocket then.
I didn't know any of this.
Yeah, so it's very, very complicated. And again, the other thing that happens is just like private insurance, when you get it from an employer, you have in-network and out-of-network now. So you got to really look at what the in-network hospitals are, the in-network providers, and then how much you travel, because if you travel a lot and get sick, you're going to be out of network, and that's a whole different out-of-pocket expense.
How did I get away with that? Because Medicare is specifically you can go to any doctor.
Yeah, so that's what you're giving up when you drop Part A and B and take Part C or the Advantage plan. Yeah.
Do you think people understand that?
I think most people don't understand that. I don't think even in the United States today, in the working population, people don't understand that, if I travel and I get sick, I'm out of network. And so my deductible is now, 35% instead of 10%, or copay 35 instead of 10. And so people don't really understand how their health insurance works because they haven't got sick very often, and they often don't get sick when they travel, so they don't have those experiences.
We're going to stop here so all of us, me included, can just kind of digest all of this. And we'll pick it up again with the next episode, that's episode 15, with more on Medicare Advantage plans, as well as the other option, supplementary plans, which pay for your share of covered services and some of the costs of any drugs that you might take. And we'll talk about the future of Medicare and ways to rein in its huge costs with more targeted preventive health care. Our expert guide through all of this is Dr. Stephen D. Culler, Associate Professor at the Rollins School of Public Health and Affiliated Associate Professor at the Guazetta Business School at Emory University in Atlanta. Thanks to Steve, I think I'm a little wiser than I was going into this podcast, and I hope maybe you are too. And of course, there's more to come. I schedule one new podcast episode a month, so look for this next episode in November. The drop day is usually the third Tuesday in every month. Updates wherever you get your podcasts, of course, and I'd really appreciate it if you'd subscribe and share. We're on Apple, Google, Spotify, TuneIn, iHeart, Podchaser, and my host platform, the Podbeam app. The video version is on YouTube. Show notes and links on my website, www.stephanieshelton.com/conversations. I'm Stephanie Shelton, and until I see you again, please take care of yourself and all those you love. Conversations on Health, How We Get There is produced and edited by Frank Harold. Research assistance from Dr. Richard Saltman, Professor Emeritus of Health Policy and Management, Rollins School of Public Health at Emory University in Atlanta.